Hey everyone, welcome back. Today we're going to talk about the RAAS, or Renin-Angiotensin Activation System. It can be kind of a complex system at first, but once you break it down, it is very intuitive. So let's get into it. So the purpose of the RAAS system is basically to increase our blood volume, and in increasing our blood volume, increase our blood pressure. The reason why it can do this is because in the heart, there is a proportional relationship between pressure and volume. So if you increase the volume, you can increase the pressure. So there are a couple scenarios where we would want to activate RAAS. So one of those reasons why we may want to activate RAAS would be in the context of low blood pressure. So again, there's so many reasons why we could have low blood pressure. Maybe it's a side effect of a medication. Maybe there is a occlusion somewhere. But in all of those cases, the kidney will want to restore the blood pressure, the correct blood pressure, by correcting the volume or increasing the volume. And kind of what goes along with that would be decreased renal perfusion or decreased oxygenated blood supply to the kidney. So a situation where we might have decreased renal perfusion would be if we had a clot in an artery that's supposed to supply the kidney. So even though our overall body's blood pressure isn't low, or we aren't physically losing blood, which is causing an actual decrease in blood volume, when we have not enough blood going to the kidney, maybe because of a clot, the kidney will still kind of treat that as a low blood pressure, low blood volume issue, and it will activate the RAAS system. So there is one more setting in which we would activate RAAS, and that would be in the setting of hypoxia. So if we don't have enough oxygen coming into our body, maybe because we aren't breathing appropriately, because we are sedated, maybe because we have a pulmonary embolism, whatever the reason may be, if we don't have enough oxygen coming into our body via breathing, we're not going to have enough oxygen for our blood to carry throughout our body and to properly nourish our organs. So the way that the kidneys respond to low oxygen is by saying, hey, the concentration of oxygen in the blood is low. How do I fix this? Maybe if I just bump up how much blood there is, I'll, cause, eventually bump up the amount of oxygen there is. So we'll get into that pathway too. So let's start off with our low blood pressure and our low renal perfusion and seeing how it will trigger the RAAS system. So we have these receptors in our kidneys, and they are called baroreceptors. And what they do is they have the ability to kind of sense if our blood pressure is low or if the renal perfusion is low. And what will happen once they sense this is happening is they will stimulate. This wants to work. Here we go. They will stimulate our kidneys, and our kidneys will go ahead and release renin. Release renin. Stepping away from the kidneys for just a second, we have angiotensinogen, which is produced by our liver. So renin will go ahead and cleave the angiotensinogen, and in doing so, it'll create a product called angiotensin 1. So we love angiotensin 1. The issue with it, though, is that it is inactive. So we can't really do anything with it until we activate it. So in order to activate it, we will use ACE, also known as angiotensin converting enzyme. And it will convert angiotensin 1 into angiotensin 2, which is now in its active form. So now that we have angiotensin 2, we're happy, and it is a great product because it can kind of do a few different things. So one of the things that it could do is stimulate either a positive or a negative feedback loop as needed, okay? And a feedback loop for the RAAS system overall. The other thing it can do is it can stimulate pro-renin receptors, which will in turn cause, in turn release pro-renin. And pro-renin is literally inactive renin. So it's kind of like a storage mechanism. And then the next thing it can do is it can stimulate a bunch of our organs to do cool things. So let's talk about some of those cool things. So first, it can stimulate our adrenal cortex, and specifically, it will stimulate a portion of the adrenal cortex called the zona glomerulosa. So the zona glomerulosa will secrete a hormone called aldosterone. And aldosterone will go ahead and stimulate our kidneys. So what it'll tell our kidneys to do is to increase how much sodium they are absorbing, okay? Specifically in a few areas, specifically in our distal convoluted tubule, our collecting duct, and the thick ascending loop of Henle, okay? So we know that water always follows sodium. So because of that increased sodium resorption, we are going to have increased water retention. And the increased water retention will help increase our blood volume. And then because of the proportional relationship you mentioned earlier, that will also cause an increase in our blood pressure. So that's how angiotensin 2 will affect our adrenal cortex. Moving on, it will also directly stimulate a portion of our kidneys. So it will directly stimulate our renal proximal tubule. Okay, so you remember we talked about how angiotensin 2 will stimulate the adrenal cortex and basically get the adrenal cortex to tell the kidneys to absorb sodium in certain parts of the kidney, like our distal convoluted tubule, our collecting duct, and our thick ascending loop of Henle. This time, the angiotensin 2 is directly stimulating the renal proximal tubule, but it'll get it to do the same thing. It again will tell it to increase how much sodium it's absorbing in that specific area. And like we talked about before, if we're increasing how much sodium we are absorbing, water will follow. So we will get that increased water retention. And then taking it a step further, as a result of that increased water retention, we will get that increased blood volume. And then because of the proportional relationship we discussed earlier, that will help us to get an increase in our blood pressure. So now we've talked about how angiotensin 2 affects our adrenal cortex and how it affects our renal proximal tubule. So stepping away from tissues of the kidney and the adrenal gland, let's look at some vasculature. So angiotensin 2 will also affect vessels that supply blood to the kidney. One of those, well, really the big vessel, will be the renal afferent arterioles. So remember, because it has the word afferent in it, these are vessels that are carrying blood away from the kidney. So what it does here is it will cause vasoconstriction of those vessels. That vasoconstriction is going to cause the pressure to go up in that filtering unit. So it'll cause an increase in the intraglomerular pressure, right? And this just means it's going to cause an increase. That squeezing of the vessels will cause a pressure increase within the filtering unit, i.e. the glomerulus of the kidney. So that increased pressure is what will allow it to maintain a steady level of filtration, even though we're having a drop in overall blood pressure, okay? So kind of a cute way to put it, simple way, would be the raise of the intraglomerular pressure, if I can say that word, will allow for a maintained GFR. This is the filtration rate in the setting of, I'm going to say global hypertension. By that, I mean just, not hypertension, hypotension. I just mean overall drop in the body's blood pressure, not the kidney's blood pressure, the body's blood pressure. So that kind of wraps up kind of the effects of angiotensin 2 in the kidney. We have two more kind of important places where it acts. The first one of those is in our brain, specifically in the hypothalamus. This one's pretty interesting. So the hypothalamus is going to stimulate thirst, okay? And so because we get thirsty, we're going to drink more water. We're going to up our water intake. And if we up our water intake, we will have to increase how much antidiuretic hormone we are secreting. And that antidiuretic hormone is what allows us to increase how much water we are absorbing from our collecting duct. And kind of like what we saw in the kidneys earlier, if we are absorbing more water, it helps us to increase our blood volume. And then again, because of that proportional relationship, it allows us to increase our blood pressure. So now we've talked about how angiotensin works in our adrenal cortex, in our kidneys, in our brain, and finally, we're going to talk about how it works on our heart. So, angiotensin 2 will cause some cardiovascular remodeling, and that is good initially because it's good initially because it allows our heart, that's supposed to be a heart, it helps our heart to get stronger, okay? But if it goes on for too long, we can start to have some pathologies that we don't want, specifically related to decreased cardiac compliance. So this talks about like why when we have patients that are persistently having like high blood pressure or that persistent activation of RAAS, we can have some heart damage. It's because of this effect of angiotensin 2 right here. So that kind of summarizes how angiotensin 2 kind of works in RAAS when it is stimulated by low blood pressure and low renal perfusion. But if you'll recall earlier, I talked about how RAAS can also be stimulated by hypoxia. So let's talk about that a little bit, okay? I'm going to kind of copy this diagram, if it lets me, on a separate page so we have a little more space to work, okay? So we talked about hypoxia. Alrighty, so hypoxia. We don't love it, right? Not great. So hypoxia, consistent low oxygen, it causes an accumulation of succinate. And if you'll recall, succinate is a product from our TCA cycle. So when we have that accumulation of succinate, it will bind to a receptor called SUCNR1. Long name. And those receptors are located on the macula densa, which are cells located in the distal convoluted tubule. So now that happens, this binding will basically trigger decreased sodium delivery to the nephron, and instead the sodium is going to get diverted, increased delivery to this sodium potassium chloride transporter, okay? And so with that, this transporter will it'll realize that there's a shift that has happened, this hypoxia-related shift that causes a drop of NaCl to our nephron, right? So it senses a decreased chloride that's supposed to be coming from the NaCl. So because it senses this drop in chloride, and remember, we don't actually care about the chloride. This drop in chloride is just kind of like let's call it a biomarker, if we will, a biomarker for the hypoxia. So it'll sense the low chloride, and it will trigger activation of COX-2, okay? COX-2 activates, okay? So COX-2 is then going to go ahead and bind to it's going to go ahead and bind to our succinate, okay? And this binding is what is going to cause a release of prostaglandins. And specifically, it's going to cause a release of prostaglandins PGE2 and PGI2. So the prostaglandins are then going to go and bind to beta-1 adrenergic receptors of the juxtaglomerular cells, which are cells inside the glomerulus of the nephron, right, of the kidney. And then this binding is going to cause an increase in CAMP. And then this increase in CAMP, gotta zoom out. This increase in CAMP is what is going to stimulate our kidneys. And that is what kicks off our renin-angiotensin system. What I want to do is draw our attention over to angiotensin 2. So remember previously we talked about, okay, angiotensin 2, it can help with the feedback loop. It can stimulate our prorenin. It can stimulate organs. Well, the other thing that angiotensin can do is it can stimulate the production of EPO. or erythropoietin. And erythropoietin is what helps make our RBCs. And remember, RBCs help carry oxygen. So that will help with the oxygen carrying capacity in the blood and kind of help with our hypoxia a little bit. So we love this hypoxia system, but we need to know how to turn it off. Like, how does it turn off? So we talked about how, right here, the transporter, it senses a drop in CL. Well, as the hypoxia improves, our NaCl levels will also improve. So what this NAKCl transporter does, it will sense adequate CL. It'll sense when the CL is better, which is an indicator for the hypoxia improving. And what that does is it triggers a negative feedback mechanism, okay? So trigger negative feedback mechanism. So when it triggers that negative feedback mechanism, what happens is our macula is going to release adenosine, okay? Source of that is our macula densa, located in our distal convoluted tubule, okay? So the adenosine goes and it activates alpha-1 receptors on our juxtaglomerular cells. And this is what these, receptors are what go and they turn off our CAMP. And because their CAMP gets turned off, the kidney stimulation also gets turned off. And that kind of stops our RAAS activation. A couple things to note. Well, really one thing to note is this. Sometimes we'll talk about how a patient for blood pressure will be given ACE inhibitors, right? One of the common side effects of ACE inhibitors is a dry cough. And the reason why that's kind of interesting is because ACE, this angiotensin converting enzyme, is located literally on the epithelium of the lung. So one of the side effects of the ACE inhibitors is basically an irritation of this epithelium, which is what causes the dry cough. So just a fun fact. But that concludes kind of our explanation on RAAS, how it's activated, kind of the details of how it works. I hope you found this helpful. Thank you for watching.